Hi, this is Andrea Kane, and we are here with HIT 352, Health Information Systems. This is now week 8 and chapter 8, Clinical Information Systems. And we are still using course objectives 8.2, 8.3, 8.4, and still learning objectives 9.2.1 through 9.2.7, 9.3.1 through 9.3.3, and 9.4.1 through 9.4.7. And you can see those in your syllabus if you're interested in that. So let's move forward. In this chapter, we are going to be looking at clinical information systems and defining those. What do they do? How do they function within a healthcare facility? And those types of things. Just like we did with administrative chapters or administrative information systems this last week. So, clinical information systems, what do? They collect and store medical, nursing, clinical ancillary areas such as radiology and lab, pharmacy, those types of areas, therapy departments, information related to patient care. So, clinical needs to equal patient care in your mind. Data contained within the information systems are patient identifiable, and therefore they are covered by HIPAA. So, what are some of the CIS or clinical information systems you will run across in the healthcare world? There will be a document management system, and that can have scanned medical records in it and some other things. But typically, it's documents that are added to the system, so to speak. Radiology information system, and radiology, the RIS is different than PACS. So make sure as you're going through this chapter that you know the difference between a RIS and a PACS. RISs typically have a PACS system with that integrated, but RISs are not PACS. So be sure you understand that. Lab information system, nursing information system, pharmacy information system, and then there is usually an interdisciplinary charting system for dietitians, physical therapists, occupational therapists, speech language pathologists, all of those allied health ancillary folks who are involved in direct patient care. Okay, emergency department as well, and then you have anesthesia because, of course, anesthesia is somewhat different than surgery. Typically, your surgery systems have an integrated anesthesia information system. But the data that they collect is sometimes shared, sometimes different. But so you'll have anesthesia information system, and you'll have perioperative and operative surgical system. You have a patient monitoring system. Now this is getting all those vital signs. This is when you have those electronic connections that are capturing temperature, blood pressure, pulse ox, all those types of things. Telehealth. Smart cards, which I'm going to again refer you back to your book for. These document management system is an electronic method of capturing and managing documents. So that's what you want to think about with document management system. It's documents. So it's not entering data, it is scanning full documents. And of course, it's primarily used by HIM because we're the ones that they send stuff to, and we have to add it in, make sure it gets into the right place and that sort of thing. So the documents can be scanned. Occasionally they're obtained electronically from other information systems. And it's more than scanning paper images. It can include voice, video, electronic transactions, other forms of technology. One thing that you will run across here is OCR, optical character recognition. Make sure you know that and know that definition. OCR, optical character recognition. It's a way of taking text from paper and turning it into bitmapped images, translating the images into a form that's then computer readable. So when you see OCR, it's essentially taking what's on a paper and turning it into something that can be read computer readable. And text can be scanned, content can be edited. Document indexing, barcoding, character form recognition are ways to link documents to a particular patient. Document indexing is typically something done when you prep, scan, QC, and validate that whole process there at the beginning of document management. Barcoding, when you go live with a system like this, you have to make sure all of your paper forms, if you have any in your organization, are barcoded so that you can make sure they get to the right place. And then character form recognition. and that allows for retrieval. An index is an organized, usually alphabetical list of specified data that serves to guide, indicate, or otherwise facilitate reference to the data. You have indexes in books, you have indexes that are just information that help you get to where you need to go. You have indexes on websites, although we don't necessarily call them that. Indexing tools allow them to locate, retrieve specific patient health record. So, for instance, I talked about prep, scan, QC, and validate. When you prep, that's making sure that you have everything in that document so that you're going to be able to scan it. Because you want that document to scan and immediately upload to the right patient, to the right encounter, to the right type of document placement area. Because in the EHR, you have sort of like little folders where the information goes. Think of it as an old paper record with tabs. The tabs in an EHR are there, and you want to make sure that if you're scanning a document, that it's going to go into the right tab for the right patient under the right encounter. Indexing is what you have to do when you can't do that with the form for whatever reason. Maybe the barcode is smudged, maybe it's missing some type of data, or it's been cut off, or whatever the situation may be. So then you manually index it. So the steps are, again, prep the document, scan it, then you're going to QA it, which is anything that didn't go to the right place ends up in a queue, and you have to manually index it and tell it exactly where it needs to go so that it gets there. So that's the QC part, quality control part, and then there's validation, where you go back and you validate that things went where they were supposed to, that there's nothing in a queue waiting that hasn't been taken care of. So prep, scan, QC, and validate are the 4 steps in document management in an HIM department. So the DMS, document management system, is not the same as the electronic health record. It's a component of it, but it's not the same. And then it gives you the definition of an EHR, and you're going to want to make sure that you know that, hint, hint, hint. Images can be retrieved by any authorized user from any location. That's one of the advantages of a document management system. Multiple users can view it at the same image, same time. Think about with a paper chart. With a paper chart, a doctor in the ED and a doctor in the office could not be looking at the same patient's chart at the same time, and they couldn't be looking at the same page of the patient's chart at the same time. And so you can see how having all of that electronic really created some synergistic benefits in healthcare, that multiple things could be going on, multiple users could be using the information. Somebody in quality management could be doing a chart audit at the same time the chart is analyzed for record completion in HIM. At the same time, somebody else is following up, trying to make an appointment with for that patient at the doctor's office, or somebody else is finishing up another aspect of the record. Maybe someone has a late entry, some documentation, maybe a dietitian who had a follow-up call from the patient's family. All that can be done when you have an EHR. The image of the scanned document cannot be searched, edited, or changed unless OCR is used, and that's one of the reasons why you have to use OCR, because otherwise, if you don't, you can't search it, edit it, or change it. And many healthcare organizations that elect to implement a document management system use it as a component of the EHR. That's really pretty much what it is. It's a component. It feeds in. So what are parts? These are parts of a document management system. You have a scanner, you have what are called target sheets, and you have a scanning workstation. So you have the actual hardware, that's the scanner, and that turns the paper into a digital image. And it looks like a desktop. I mean, you can have really small ones that look like a tiny desktop, like a box of Kleenex almost, that are fairly small. And then you can have ones that are the size of a big DeskJet printer that do more. And so it just depends on what your needs are. If you only have a handful of documents that you're going to be doing, you could have only 1 or 2 workstations set up to scan, and you might have a small single sheet type desktop scanner or something that can take up to 10 pages. versus if you have huge paper files that you are converting. You will definitely want one of those very large, heavy-duty, big desktop scanners that you can put 50 to 150 sheets in and scan. Target sheets, those only contain a barcode. They tell the scanner and computer the content of the pages that follow. You usually typically use those when you're either scanning a whole stack of documents that are all the same type of document but not the same person, or if you use a target sheet for the patient because all the documents belong to that patient, but they're different types of documents. You just want to make sure that on your forms that you're scanning, that for instance, in the first example I just gave you, if you are scanning, say 100, I don't know, anesthesia records, 100 handwritten anesthesia records, you're going to want to have a target sheet that says these are all anesthesia records, but on each anesthesia record, you want to make sure there is a barcode with patient ID on it. Otherwise, that one will go into the queue that has to be manually indexed because it won't go anywhere. It'll say, yeah, this is an anesthesia record, but I don't know what patient to put it under. I don't know what account to put it under. So it's just going to go to a queue where somebody has to manually index it. And the same thing with a patient. If you take patient XYZ's medical record to scan in and you have your target sheet, it will scan all those pages to that patient, but it won't know where to put them if the barcode for the form itself is not on there. It'll know the patient in the encounter, but it won't know where to put it. So again, it'll go to a queue where it has to be manually indexed to say, yes, it does belong to this patient in this encounter, but you're going to have to tell me what type of form this is so I know where to put it. And that's where you get into the manual indexing again. And so then you've got your workstation, which is desktop computer that hooks up to the scanner, and they work together and process it. So there you have it. You have an abstracting and quality workstation, quality control. I talked about the prep, scan, QC, validate. So you have a station for people who are doing quality control. And that's where they're doing the manual indexing, they're doing quality control, they're checking those queues, making sure everything goes where it's supposed to go. They are also looking at quality of image. If the scanning, for whatever reason, the scanner didn't pick it up, or it skewed the page and it didn't get properly done, then it either needs to go back to a scanning workstation where somebody can rescan it, or what we found to be most efficient was we had our QC workstations with tiny Kleenex box size scanners, and so if they had an image that wasn't right, they would take the paper right then and there and they'd go ahead and scan it, upload it, and take care of it right at that point so that it didn't have to go back in the process. But we did keep track of when that happened, who did it, and how, was it an accident, was it the scanner, was it the person who was scanning, so that we gave feedback to say, hey, you might want to watch this or be aware of that, or oh, we found, maybe somebody left a staple in and that caused the first image to go through fine, but the second one got tangled up and it had poor quality image and that type of thing. So that's what goes with that. And then there's a file server that receives requests for document images, retrieves document images, and sends those back to the requester. And then there's a retrieval workstation, and that's where people can view document images. And I have to say, today, for the most part, people use their own workstation. It's not a separate workstation. It's pretty rare that that's a separate workstation. Printers, yes, you need to determine who has the right to print reports from the DMS, because think back to HIPAA and think back to your disclosure log. You need to know who's printing, where it's going, and how that's, whether or not that needs to be tracked for accounting of disclosures. And you also just need to know people are not going in and willy-nilly printing stuff, and where, because stuff can walk outside the door of the organization if just anybody can print at any time. You also have to track the printing. There has to be a way that you're tracking who's printing and what are they printing, and be able to go back and take a look at that. Again, who requested, submitted the print order, where did the printing occur, what printer was used, where is that located in the facility. date and time of the printing, what exactly was printed, and then anything else you'll need. Because again, you've got to keep track of all of that information. All right, annotation, that's the ability to add to the image in some way. That is, for instance, a physician can add a note to the image. Someone can highlight important sections of text that they want somebody else to be aware of, or they want to communicate to someone else. They can draw circles, arrows, other markings. A lot of times you see this with something like radiology, where they'll draw a circle to draw attention to something. There's zoom and reduction, where you can enlarge or reduce the size of the image so that it can be better viewed. Rotate it. Sometimes you need to flip the image. When it gets scanned, for whatever reason, it scans in upside down, and you need to be able to rotate it. So those are all steps and types of annotation. Advantages and disadvantages to a document management system is a lot of space savings. You can retrieve a large number of records. There are productivity gains, online availability of information. However, you need to make sure you have very good system security and control. You will have opportunities for database retrieval, but your lack of manipulation or reporting can be an issue, and fear of change. So it's just some things to think about. Your book covers these too. So when you implement a document management system, you do something called backscanning. You figure out what past health records are going to go into the document management system. So for instance, let's say you're going to go live on a Wednesday. Do you go back to that Monday or that Sunday and backscan all those records? If you decide that you're going to start scanning at 7 a.m. on a Wednesday morning, do you go back and you start from the records that were started at midnight? You have to figure out how far back you're going to go. You're going to go to the beginning. If your go live is set up for the 15th of the month, you're going to go back to the 1st of the month. Where are you going to draw that line in the sand so that you know? And then it can be performed by HIM or outsourced to a vendor. And I'm not going to get into which is better or which is worse, because I've dealt with both, and that would be a long lecture, so let's not go there. All right, so justification of costs, that can sometimes be challenging, but most organizations are beyond this. They know they have to have a document management system if they have any number of paper forms going into an EHR. If they pretty much have been on an EHR for a long time and they have next to no paper records, they will still get a document management system in case there's a downtime type situation, but it won't be quite as robust as what we have talked about. What we have talked about is really what happens, or what happened 5 to 7 to 10 years ago when EHRs were fully implemented across organizations across the nation. So a lot of this is kind of old information, but you have to know it just to be aware of it. It's kind of like paper records. We talk about it, but it's so rare and few and far between. I talked about forms being barcoded and what that was all about. Staffing changes, you absolutely will have staffing changes. Some people can adjust, some people can't. And again, that could be a whole different lecture we could have some time about the ways to approach that. There's usually a place for everyone, unless someone is totally entrenched, and even if they are, there's usually about a 6-month period of time where you're still dealing quite a bit with paper, and you can utilize those folks who don't want to transition into a more technological role. So just keep that in mind. Process redesign, absolutely. It changes everything. You don't want to take what you're doing in the paper world and just slap it into an electronic world. You truly want to make the technology work for you. So that means redesigning a lot of processes. When to scan the health record, there are some people that want to do it immediately after discharge. There are other people that insist upon completion. And then they don't have it here, but we used to go up to the floors a couple of times a day, usually I would say 4 times a day, pick up anything that was paper and immediately come scan it. We didn't wait for discharge. We didn't wait for completion. We knew that people were getting into that electronic system. They needed that information now. They didn't need it sitting in a basket somewhere, either on the floor or in medical records, which increases the potential for it to be lost. So I would say actually both immediately after discharge and upon completion are both the wrong answer. It should be, the record should be getting scanned as it is created so that it is as close to completely electronic and concurrent as possible. So there you have it from me. But again, Read your book because you'll be tested on what the book says, not what I say. Because the HEMA doesn't write their RJT exam based on real world and what those of us that have lived it know it. Okay, so retrieval of images, that's one of those things you've got to make sure everybody is trained to be able to retrieve. And then what is your future of your document management system? What happens when you go from scanning thousands of documents a day to scanning maybe 10 a week? How does that change things up for you, and what does that mean? All right, radiology information system. So much more interesting, I think, to talk about. That is where they collect, store, and provide information on radiological tests, and gives you some examples there. It also includes the radiology procedures that are performed in radiology, the interventional procedures, things like that. It does perform many administrative tasks. So RIS has a scheduling component, it has charge components, it has reporting components. It can track your supplies like nuclear materials, and it allows for usually front-end speech recognition. Although there are systems that do back-end speech recognition as well as transcription. It just varies. Retrieve test results, fax those, and again, you're sort of talking of a release of information system, so you have to make sure that all of that is being recorded and it's captured properly so that you've got it for your accounting of disclosures. And then it monitors supply inventory. We talked a little bit about that. Okay, PACS. PACS is different than a RIS. They are typically integrated with a risk. A PACS and a risk, usually you purchase both. They are often made by different companies. But they are integrated. And PACS is what obtains, stores, retrieves, and displays the digital images. So when you think of PACS, think of digital images. When you think of the RIS, it's everything but the digital images. Then you have X-ray films and all the other stuff. Those are stored digitally, and that way you don't have physical films to manage. And having worked closely with radiology, when they have had RIS implementations and PACS upgrades and PACS implementations and things like that, they are thrilled to death to be able to start destroying old films that they no longer have to maintain. Teleradiology, that's the ability to view radiology images from any location by any radiologist and other users. Typically, teleradiology is done a lot of times during the night. Especially smaller community hospitals can't afford to have radiologists on 24/7, 365, so they have contracts with teleradiology companies that provide teleradiology services during the hours when they don't have a radiologist on site. And the teleradiologist has access to the system. They're credentialed by medical staff, and they go in, they review the images, they do the reports, all the same as you would if the radiologist was employed directly by the organization. And so that's big. There are huge teleradiology companies. You have a lot of East Coast firms that review films for, West Coast firms that review for East Coast hospitals because of the time difference and that sort of thing. But it can be done from anywhere around the world as long as you've got connectivity. And then, yeah, radiologists sometimes read images from home, and occasionally it's used for consultations. Lab collects, stores, manages lab tests, respective results. It really makes sure that those critical values are reported because it alerts on those and makes sure that they get delivered not only to an inbox but maybe through a text message and other things. So the lab information system is an important one, and it is integrated in the EHR. Physician order entry. Physician order entry is used for lab, radiology, pharmacy, pretty much anything. The orders go through and it identifies the tests that need to be run. Occasionally it can schedule them, and if they need to be done at a certain time or within a certain time frame, within the next 4 hours, within the next 2 hours, and then it identifies where the patient's located and whether or not the test is routine or urgent. So CPOE is integrated with lab, radiology, pharmacy, and pretty much others. There's also, like an order for a dietitian, for a nutrition consult, as well as orders for rehab and things like that. Although a lot of those orders are put in sometimes by nursing, but CPOE works hand in glove with all of these systems. So what else does lab information system do? It prints out specimen labels, and they use barcoding big time in the lab. That's another huge place where they barcode everything because they need to be able to scan it to identify patient, identify encounter, identify the test, those types of things. So typically, if you're going to have, let's say, 3 lab tests, maybe blood, urine, and sputum, they will print out, and let's say you're going to get 3 different blood tests run. They're going to print out a label for the urine, 3 separate labels for the blood for each test, and then 1 for the sputum. And so you'll have all of those, and they'll identify. Again, we talked about panic or critical values, very high, very low. It identifies those of that, identifies normal ranges, marking the values high, low, or critical rather than panic. I would say critical is a more appropriate word. I talked about printing barcodes, quality control activities, management and lab reports, charges, of course. And then we move on to nursing information systems. And with nursing, theirs really comes down to documentation. They are documenting the interventions, the nursing interventions and assessments that they're doing. Sometimes you'll run across an EHR that has different, and you should, I mean, ideally, you should have specific nursing clinical documentation for the ED versus intensive care versus a regular nursing floor versus labor and delivery, because they all are capturing different data based on the needs of their patients and their specialization. So you don't want to see that your admission assessment is perfectly identical for every patient in the hospital, because your admission assessment for a labor and delivery patient is going to look very different and have very different questions on it than your admission assessment for someone coming into the ICU. So just keep that in mind. And then same thing in terms of some of the other things that go on. So advantages to a nursing information system, you can read all those here. There are lots and lots of advantages to a nursing information system as long as nurses know how to use it and they use it consistently and they don't write things on paper and then 6 hours later go enter them into a computer. That's when you get to a disadvantage. But overall, nursing information systems are a godsend. And if you are a coder, you will find that, because if you have to go hunting for something that maybe a nurse has documented to validate some information, it'll be there. And this gives you some of the documents that are traditionally included, like admission assessment, the nursing interventions that they do for the patient, intake output. The graphic is their temp, their blood pressure, their vital signs, those types of things. Activities of daily living. Did the patient get a bath today? Were they able to get up out of bed? Did they sit in a chair for a while? Did you take them for a walk down the hall? Those types of things. Or if they're bedridden, did you turn them? When did you turn them? How did you turn them? Where, on which side did you turn them? How long were they there? All those types of things. Nursing care plans based on the patient's diagnoses. What is the nursing care plan? How are you going to address all their needs? And then nurses' notes, if there's something going on that's out of the usual, to make sure that that's documented. And then, of course, the medication administration record. That is part of the nursing information system, but it interfaces with a pharmacy information system, because a lot of times pharmacy will have their information stored in like a Pyxis machine, or there's several other commercial brands, but they'll have them stored there. They'll be barcoded. The nurse will be able to use a barcode reader or wand to attach that medication that's in the pharmacy system to the patient, and it helps to be able to follow what was given to what patient when, and that sort of thing. And then there's, of course, monitoring staffing, scheduling, and looking at performance improvement. Pharmacy, that really assists providers in ordering, allocating, administering medication. They are looking at preventing medication errors. And also, I mean, they're looking at, okay, what does the pharmacy have? What is the pharmacy's formulary? What is the pattern of ordering by physician and overall by the organization? And what's look alike, what's sound alike, and those types of things that patient safety is really focused on. And I just talked about that, reducing medication errors, looking for food-drug interactions, drug-to-drug interactions, other contraindications. Managing the inventory of drugs, again, talked a little bit about that. And dispensing medications, talked a little bit about like Pyxis systems and other, where they have, it looks like a gigantic refrigerator with a glass door on the front, and they have little bins in there, and the bins are labeled, and they have IVs in there, IV bags in there, they have medications, they have syringes, they have pills, they have everything, and it's in there based on, well, some choose to store it by patient, and some choose to store it by what it is. It just depends on the organization and which way they prefer to do it. And it's locked. You have to have a code to get in, so it identifies who's unlocking the storage system. And then, of course, like I said, there were barcoding and that sort of thing. Interdisciplinary charting system can be used by any healthcare professional to collect and store patient assessments, progress, and care plans. That means your physical and occupational therapists, speech therapists, respiratory therapists, dietitians, all of those that are providing direct patient care but are not in a specific physician, nurse, pharmacist capacity. So, or radiology, that type of thing. And respiratory therapy oftentimes will have their own modules in the system where they're again tracking what medications are being used, what interventions are being used, and if a patient's on a vent, when were they intubated, was the intubation at any time, did the patient accidentally extubate themselves and have to be re-intubated, when did they wean them off the vent, and how did that whole process occur, and when were vent setting changes and all of that. All right, emergency department system. There are a lot of things that are unique to the emergency department system. You think about EMTALA, you think about arrival, triage, disposition, you think about just how the ED is very different than the other departments because everything is so time crunched and everything is focused on stabilization and moving them to the next level of care or being able to release them home and how all of that works. So ED systems are typically a little bit different than others. I'm sorry, let me go back to that. A lot of times with a document management system, you'll scan in EMS records if EMS is still on paper, which you hope at this day and age they're electronic. Most EMSs should be by now. And so that should also be filling the emergency department system as those EMS records. But if they come in late or they come in paper form, a lot of times they end up going through HIM through a document management system to be reunited with the emergency department record. They also notify state authorities about diagnoses, but typically they don't do that directly from the ED. That a lot of times goes through infection control or quality management, but you can gather data through that. They have to track injuries due to mass casualty events and natural disasters. I heard something this morning on the radio that reminded me that even in Iowa we have hurricanes, we just have them without water. Speaking about the derecho storm. So yeah, I guess we do have hurricanes here. All right, anesthesia information system, talked a little bit about that earlier, but it collects information on pre-op, operative, post-op, or I should say pre-op, peri-operative, and post-operative anesthesia related clinical information. Follows them through the surgery process and into post-op where they're in the PACU unit, post-anesthesia care unit, and they're getting monitored through all of that. It does collect information on risk factors, vital signs, and anesthesia. And then you get into patient monitoring systems. Examples of this are when they collect vital signs like O2 sats and fetal monitoring. And they are typically utilized in specialty areas, although really, you think about vital signs, that's pretty much across the whole hospital. Telehealth, I'm not going to speak too much about this because I think most everybody knows about telemedicine and you can read about it in your book. So I'm going to kind of fly through these slides. We know the benefits of telehealth. Certainly living in a COVID environment has brought this home to us. And here are some more benefits. And telesurgery is a type of telehealth, but it's using robotics to perform surgery. Telesurgery can be done remotely, so you could have a doctor that is in a different location that's using the robot in surgery that's actually doing the procedure. And of course, you know, we need to remember HIPAA when it comes to telehealth, telemedicine, telesurgery, teleradiology, all of the teles in life. And then liability is shared, but it's typically between the provider, consulting provider. It's between the organizations, not the vendors. And then licensure and accreditation rules vary by state, and no federal legislation for telemedicine at this time, but I bet you'll see it in the next few years, so keep your eyes open for it. There are concerns about fraud and abuse, although it's so fairly new that not a lot of it's been uncovered, but that's certainly an area of concern. So if you are someone who is coding or billing for telehealth services in any way, shape, or form, you're going to want to make sure to double and triple check before you release your stuff, especially if it's going to CMS, because you're going to want to make sure that, because they will come down very hard on it because it is a new area, and if they see fraud happening or abuse happening, they're going to want to deal with it, to crack down on it, because so much money is being spent on it and will continue to be spent on it. So make sure you have good policies and procedures and that you have lots of clear documentation requirements. Okay, so smart card just talks about here about what smart cards are and how they're used. Smart cards have been introduced several times over the last 15 to 20 years. They have been somewhat accepted in some places, but most of it really hasn't worked well. Smart cards can get lost, they can get damaged, they can get demagnetized, and all the other things, and so it's not the best solution, but it's one that is being utilized in some places. All right, that's it for this one. So I will be back soon to talk to you about chapter 9, and that's going to be the electronic health record, the EHR. I hope you're doing well. Hope you're enjoying this beautiful week of weather, and take care. Talk to you again soon.